let me just start by acknowledging and thanking our public health officials who have been working tirelessly, obviously, through these last 10 months, and especially relative to the rest of the state. There is no question that the infrastructure that we have set up is effective in our turnaround time once we receive the vaccines and getting them into people's arms. That is undeniably been very effective. I also appreciate the efforts over the last few weeks to improve the website communication. I think the registration system so that people can receive alerts is effective and helpful. And as I said recently, publicly, I feel like we are doing a reasonable job of controlling what we can control. But as has been stated, and as we have talked about on numerous updates and briefings, there is a lot we can't control. And so I to the residents that have flooded us with emails and correspondence since the Washington Post article just this morning, which stated that residents in Northern Virginia and in the District of Columbia have already begun their phase of being able to provide the vaccines to people over the age of 75. There's just understandable frustration, confusion, and frankly, growing anger that our state has not been able to move more quickly. And so I guess my question primarily for the team is, why is that? Was it a policy decision at the state level? As of yesterday, Virginia had administered 180,000 shots and Maryland had administered 140,000. Did Virginia concentrate most of their doses to the areas with the highest concentration of cases around Northern Virginia? And while we have received a larger share here in Montgomery County, there has been a more even disbursement across the state, even to within jurisdictions that haven't had anywhere near the level of community spread that we've had in some of the larger counties. So to the best of your knowledge, is obviously, and it's also troubling that we don't know exactly how many vaccines the state has at its disposal, and in some ways are flying blind in terms of how we're able to administer our own vaccines here. I do have specific questions to our operation, but before I get to those, if Dr. Stoddard or Dr. Crowell, any one of you, or Dr. Bridgers, any one of you is in a position to describe from your perspective what the state's approach has been from a policy perspective in the administration of the vaccines, which is directly tied to why we are still in 1A and other jurisdictions have already moved on to their next phase.
Sure. Thank you, Council Vice President Albornoz, for that question. To the best of my knowledge and in conversations with Dr. Gales, and he's been in more conversations with the other health officers across the local jurisdictions, my understanding is that some of the smaller counties who receive their doses and have the capacity to move to 1B were asked to hold. And I don't have the backdrop or the story around that. I know that they're trying to move in unison, but in some jurisdictions it may hinder on the progress in other jurisdictions. And so I do know that most of the guidance and policy is set by the Maryland Department of Health, as well as the allocation of vaccines. And that's as much as I'm able to share during this briefing to Council this morning.
So the bottom line, go ahead, Dr. Stoddard.
I was going to say, I think that Dr. Bridgers has it correct. I think in my view, the state may have misestimated where the priority group populations were. And so you had jurisdictions that received more doses than they had people in category 1A, and were able to complete those over the first week of vaccinations and have extra doses that they wanted to move into category 1B with. I think if those distributions had been more accurate in their distribution across the state, we would be further into our 1A and they'd be finishing up their 1A and we would be all in sync. And now we've got this discongruency that is emerging over the state, where the larger jurisdictions with more primary care providers or more healthcare workers are lagging in terms of percentage relative to the smaller jurisdictions who are fully through 1A. And so I think if those estimates had been better earlier on, you would have a more even distribution of jurisdictions ready to move into phase 1B. I don't think it's going to be a vastly different amount of time. It's going to be a matter of weeks, but I think when we talk about weeks right now, that's too long. And I think we all agree with that. I think we would absolutely like to be have had more vaccine, and we would be through 1A at this point if the distributions had been more accurate.
Yeah. I can't speak to just one other thing. I can't speak to Northern Virginia's or Virginia and their process around how they did the allocation. And talking with my counterparts in human services around health and human services around the state, they are as equally in the dark about sort of the process and the flow and the state's decisions about distribution of vaccines as we are. DC, of course, being both state and local, manages that process, and with a much smaller number of healthcare, much smaller population, both in terms of 1A and others, their ability to move into 1B is not surprising given the size of their population and the number of people they have to vaccinate. We are moving pretty fast with getting through our 1A, and I think we will continue to do that and get there and get ourselves into 1B over the next several weeks. I'm certain. But it just takes us longer. We've got a large number of healthcare providers.
And I would also note one big thing too is we don't know what the uptake rate is in any of these jurisdictions, meaning that we may be in 1B in a week from now because we don't get as many people coming in through this, tier 3 category of 1A as we thought. That's not particularly good news. I mean, it would be good news that we got into the 75 and older population, but it would also mean that there would be a substantial number of our primary care providers who are refusing to take the vaccine, which has other implications because they would then potentially not be advocating that their patients get it at a later point if they're unwilling to get it themselves. And so obviously we're kind of hoping that a number of our primary care providers come in and get vaccinated. Maybe that takes a little bit of time because so many of them are interested, but I think we don't know that until we start taking those folks in and having them come in and get vaccines and taking those reservation slots.
So needless to say, it's frustrating is not the right word. And there needs to be accountability at the states. And so I think we are going to have to work with our delegation in ensuring moving forward that there is accountability for what has transpired. To Dr. Bridger's point, we have the capacity in Montgomery County to provide between 2,500 and 35 vaccines per day. That's 17,000 to 24,000 per week. And last week we received 6,700 vaccines. And we are hoping to receive 12,000 in the upcoming week. So it's clearly a supply and demand issue, and the state needs to reallocate and pivot its policies immediately in order for us to be able to vaccinate the regions in which there has been the highest concentration of spread, the greatest amount of deaths, and it is absurd that we have not been able to achieve that. And so my frustration is not to our public health team, but to our state officials who have not been transparent, who have not provided clear communication, and who have not been doing their job. And so that needs to be addressed, and it needs to be addressed right now. With regards to pivoting to local communication, Dr. Crowell, I appreciated your comments with regards to establishing a registration system to avoid the pitfalls that we have seen in Florida and frankly, even some of our neighboring jurisdictions who are, understandably being overwhelmed by requests from people within that category. What is the time frame for the type of registration or technology solution that we are exploring right now? Are there additional resources that are needed to be able to stand something up so that whether it's a week or 2 weeks from now, when we finally can begin to administer the vaccines into our older adult, more vulnerable populations, we are better prepared than other jurisdictions based on those lessons learned?
So I'm going to say, obviously, I'm a healthcare professional, clinical psychologist, not an IT person, but this is there's a technical solution that has to get put in place around this. I believe that we should be able to adapt some of our existing solution to get folks pre-registered in our system, and then we can move them into the PrEP mod system when it is their turn to be registered. That is a system that basically identifies folks by age, by date of birth, by age, by race and ethnicity, by zip code, there's a few demographics, and by any kind of special needs, I think, that they might have, so that we can get a sense of the numbers of folks that are interested and the numbers of folks that we would prioritize. So it'll take a minute to get that technical piece in place, in operation. I'm guessing, it's a week to 2 weeks, but I'm not sure. It could be a matter of days, just depending on how much adaptation to our existing system has to be done. That, I think, the good news on that is that while we will have to take the time to get that in place, my sense is that as we progress through layers and tiers of the population, when we go from 75 to 65, the adaptation will be a minor adaptation that allows us to expand the eligibility groups. So it could be a very minor tweak in our existing process. So that's the piece I can't answer for you right now.
Okay. Obviously a high priority. Dr. Stoddard, you were going to say something.
Yeah, I was just going to say, I think it's important to understand, even as we may be able to get into the 75 populations sooner, depending on what the healthcare, because obviously we've talked about the Southwest model for boarding, where you're not going to wait till all of one category is through. But I think the key thing to understand is with every new group that's added on, it'll be while one group is ramping down, the other group is ramping up. And so the initial allotment for, initial ability to get to 75 may be very limited, and it would expand thereon until we got through everyone. It's just important for everyone to understand that it wouldn't go from doing nothing in one group to doing all of the group the next day. It will be a transition out of one group and a transition up into a new group. I think it's just important.
The other, you're right. And the other piece of that is that just in terms of a registration system, any kind of system we set up, we also have to set up a process for how people and when people can log on to register. We do not want to have a system where everybody rushes the system and crashes the system, as we saw happen in Florida. I think we're not in any real danger of that, but structuring how people come into that system is the other piece of this we'll have to do. So it's not let's turn this on tomorrow and let's say to everybody, come get in. We also, some of the other problems we have to solve around this will be dealing with folks with limited access to internet and technology, and folks who are, like myself, a digital tourist rather than a digital native, and the support that they need. So it's whatever we're doing in terms of online, we probably are going to have to match with some call capacity. So this is, to Earl's point, we're going to be building this in stages as we go forward, starting with the online piece, but then moving out to other things.
Okay, I appreciate that. Just just two other points for context and then one final question. So just in the last 12 hours, the CDC has announced that they're not as concerned about the length of time between the first and second shot. In other words, and then that was followed up by an announcement just as we were talking from the federal HHS that there's going to be a higher degree of rollout so that more people can get that first shot, given what the CDC has announced. So that hopefully will mean states will receive larger percentages of dosages more quickly. That's a significant policy decision at the federal level, which will trickle down and improve rollout. Should have been done obviously before, but that is good news. Final question is relative to our developmental disability community, which everyone acknowledges, and I do appreciate the governor placing them in 1A, along with the service workers, and acknowledging this congregate living facilities, particularly within our disability community, have a disproportionate impact. Also acknowledge that they have been directed to Walgreens, CVS as part of the federal program, based on the policy that has been laid out by the state. But understandably, from the developmental disability community, there's tremendous frustration because, of course, Walgreens and CVS have not been able to stand up their tests yet. And so they're being directed to operationally a group that can't help them. And so my question for our team is, should we consider, given that Walgreens and CVS has not been able to stand up and has not even given a time frame for when they're going to receive their dosages of federal vaccines, including them within the county's response, particularly Dr. Stoddard, given that it looks like there are some slots being unfilled. Because as we saw early on in the pandemic, there is tremendous spread that occurs within this congregate living facilities, nursing homes, group homes. Should we be exploring that, acknowledging that goes against the stated state policy, but doesn't help the folks that are on the ground experiencing this crisis?
So, Councilmember Albornoz, I'll respond, and Doctors Crowell and Starter can add. I've had multiple conversations over the last 4 days with key stakeholders, specifically Dr. Greenberg, about the same thing. And so, if there are doses available, we at the local level continue to be the safety net, and we would look at those appointments and those scheduling. We're working on a plan. We're having discussions about that very same thing. If those appointments are available, to allow those individuals who work in those congregate spaces the opportunity to receive a vaccine. So we're working on that as we currently speak, and we have addressed the need, and we will present that yet again to the Maryland Department of Health as a shortcoming regarding the most vulnerable populations.
Well, I would add to that the challenge for us first is to get a clear sense, an absolute clear sense of what the state is and is not going to do and is ready to do, so that we don't get cross-wired with them and start confusing the public around in messaging. So that the first task is to really get clear with them so that we can put out a public message about what they're going to do, and then we can make offer some clarity about what we can do to backstop that if there's a gap. Assuming
I think adding to Dr. Kroll, adding what Dr. Kroll just said, I think it's really important. It's not just what they'll do, but along what timeline they'll do it. Yeah. And I think that's what we're really trying to understand, is because our understanding is that the nursing homes should have all received first doses at this point, and they should be moving into assisted living facilities and presumably then onto DDA providers. But obviously, we would feel discomfort. We talked about this moving into our phase 1B if there are still organizations in phase 1A who, through the federal contract or through the state effort with hospitals, we're not getting vaccinated along the same pace as other 1A providers. And so, as we are moving towards a completion of our efforts in 1A, we're trying to understand whether everyone who's receiving 1A prioritization, whether it's through us or elsewhere, is having that opportunity provided to them. And so we absolutely are committed to making sure that DDA providers are covered as part of 1A. And I think we've all expressed a recognition that if we have to step in as a county to help those providers, we will do so in the same prioritization.
Well, I think we should add that to the list of grievances with state officials who've not made things like this and that have real practical implications for providers more clear. And we need to do that today, because if we don't get a reasonable response within the next 24 hours, then I do think we're going to need to move forward with administering these vaccines to this highly group that's significantly at risk, as we all acknowledge. That's why they were put in 1A in the first place.
Well, I just wanted to raise a point that to do that means that we are delaying the onset and the degree to which we move into 1B, so into the 75 and older population. So there's an issue around that. It's not. I don't know that it's that the number is all that great, but if we do that, then we are going to delay. It will add to the number of folks that are in 1A and lengthen the time we are in 1A before we can move fully into 1B.
Understood, but we gotta deal with the issues that are on the ground. We can't just wait for the state, and so it's that seems pretty clear at this point. So, go ahead, Dr. Starter, you're saying one more thing.
Yeah, I think just one quickly state. It's really important to understand this is a federal contract, and the state does have responsibility here. But I think we also need to be working with our federal delegation to be putting more pressure onto the federal HHS system, particularly as we get into the new administration, to ensure that they're moving more quickly along that contract. I think that the state has an ability to apply pressure. I do also believe that we need to be working with our federal delegation. I'm actually texting back and forth with Ms. Connor from Representative Raskin's office to try and put some of that kind of pressure onto that federal infrastructure as well.
Thank you. Apologies to my colleagues. I know I took up a lot of time, but I defer back to you, Mr. President.